Bismillahirrahmanirrahim. Welcome to my channel Science of Life with Dr. Mohammed Yusuf. Today we will continue the discussion of the cardiac failure. In the previous lecture, we discussed cardiac failure and a few things left we are going to discuss today. But before that, one ayah from Holy Quran, ayah from Surah Tawbah, ayah number 111. Brother, it is the part of that ayah. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إن الله اشترى من المؤمنين أنفسهم وأموالهم بأن لهم الجنة إن الله बेशक अल्लाह ने इश्तरा खरीद लिया मिनल मोमिनीना मोमिनीन से मोमिनों से क्या खरीद लिया अनफुसहुम उनकी जानें व अम्वालहुम और उनके माल बिअन्न लहुमुल जन्नह जन्नत के बदले में। तो अल्लाह पाक ने मोमिनों की जान और माल जन्नत के बदले में खरीद लिया। मेरी जान मेरे अल्लाह के, मेरा माल अल्लाह के लिए। अगर ये नौबत आ जाए तो फिर अल्लाह पाक का वादा है जन्नत। तो अल्लाह पाक ने ख़रीदा हुआ है मोमिनीन से, अल्लाह पाक ने ख़रीदा। हमने जो सबमिट किया ना, टोटल सबमिशन, इस्लाम इज़ दी सबमिशन टू अल्लाह। हमने ये सबमिट किया है कि हमारा सब कुछ अल्लाह के लिए है, तो फिर अल्लाह ने उसके बदले में अल्लाह पाक ने जन्नत तैयार रखी हुई है। अल्लाह पाक समझ अमल की तौफीक अता फरमाए, हमें शौक दे जन्नत का। So we are going to talk about the cardiac failure. We discussed, this is again definition, the old slide, that is a state in which the heart cannot provide sufficient cardiac output to satisfy all the requirements of the body, metabolic needs of the body, or it is commonly known as CCF or CHF because the venous congestion is very common. So when the heart is not able to obey the Frank-Starling's law and the cardiac output is less than the venous return, so it is cardiac output. Two important features we were discussing: reduced cardiac output and the retention of the fluid, damming of the blood in the veins. Veins, they are engorged, they are congested, and that may result into edema, we are going to say today. This was the last thing which we discussed, compensated cardiac failure. When compensation has occurred and this compensatory mechanism, all the compensating mechanisms have achieved the normal cardiac output, and this is the compensated cardiac failure, in which cardiac output has returned to normal and total pumping ability of the heart, though it is reduced, cardiac output, cardiac output has returned to normal, but the right atrial pressure is at 6 millimeter of mercury. We saw that diagram. So it cannot further increase the pumping effectiveness of the heart. So compensated cardiac failure, cardiac output is okay, 5 liter. At rest, this is sufficient. But when the person goes into some activity, then this 5 liter cannot be pumped in that condition. Then more than 5 liter required, so further increase in the cardiac output beyond 5 liter may not be possible. So it is the compensated heart failure. Right atrial pressure has been raised and the cardiac output is sufficient during rest, but exertion may cause the return of the symptoms of the cardiac failure. So maximum pumping ability is only half or maybe less than half. So heart is not capable of increasing pumping ability. Cardiac reserve is reduced. We are going to see different conditions in which cardiac output. Any cardiac failure, cardiac reserve is reduced. Compensatory mechanism, though they try to bring the cardiac output to normal level according to the requirement, but cardiac reserve is reduced. These curves we saw, that is, this curve is this is normal curve, and this curve is the cardiac output curve. In compensated cardiac failure, this greenish curve or the yellowish curve, that yellowish green curve, the cardiac output is 5 liter, but further increase like this was 5 liter, and further increase, this was 5 liter at 0 millimeter of mercury. This is 5 liter at 6 millimeter of mercury. So increase in the right atrial pressure will cause here, but increase in the right atrial pressure will not cause further increase in the cardiac output. Increase in the right atrial pressure with the normal heart up to 2 will cause the double cardiac output. But here the beyond 6, 7, 8 further increase because plateau has been achieved. In this heart, maximum pumping effectiveness has been achieved. This is maximum pumping effectiveness. So further increase may not be possible. So this is compensated cardiac failure. And now the person is not in cardiac failure as long as the person is sitting. But slight activity may return the symptoms of the cardiac failure back to, will cause the returning of those symptoms. Now, say if the compensatory mechanism cannot compensate, cannot bring the cardiac output to 5 liters. So it will be decompensated cardiac failure. So when the heart muscle has been extensively damaged, this sympathetic stimulation or renal retention of the fluid, increase venous return, etc., we discussed in the previous lecture, may not be able to bring the cardiac output up to required level, that is 5 liter. हमने 5 liter फर्ज किया हुआ है, up to 5 liter per minute. So when heart muscle has been extensively damaged, then the compensatory mechanism by the sympathetic nervous system and by the fluid retention, these were the two compensatory important mechanisms. These compensatory mechanisms may not restore the normal function. So when this is the condition, this is decompensated cardiac failure. The person remains in cardiac failure, cannot recover exactly to the 5 liter level. So they cannot restore the normal. So cardiac output cannot be normalized in this person because of the extensive damage to the heart. We took the example of the cardiac failure because of the acute myocardial infarction. Other causes are there as well. So cannot cardiac output cannot be. So urinary excretion of salt and water is greatly impaired. When there is reduced cardiac output, reduced blood flow to the kidney, that is the renal functions are impaired. Renal failure may occur. Then if there is severe shock occurs, we are going to discuss the shock in next lecture, inshallah. Because of this cardiac failure, the person may go into shock. So if severe shock occurs, the renal anuria may continue and it may cause the renal failure as well. Severe shock the people may die of the renal failure. So the urinary excretion of the salt and water is greatly impaired because of the decompensated cardiac failure. Excessive fluid retention and edema will occur because there is no decreased blood flow to the kidney will reduce the GFR tremendously and complete anuria may occur. Complete absence of urine may occur. So where that extra fluid will go, it will be excessive fluid retention will occur. When excessive fluid retention occur, it will be passed on into the interstitial fluid and edema will occur. Decompensated cardiac failure. This is the diagram. That is, say the acute myocardial infarction has resulted into the cardiac activity, cardiac output curve at A level, and compensation has brought the sympathetic stimulation has gone to, it will go to B, and with the compensation with the urinary retention it may go to the C, but it never touches that line. When it cannot touch, the compensation cannot bring the cardiac output to the required critical cardiac output level for the normal fluid balance. So if the cardiac output remains less than that critical level, which is 5 liter per minute here, so if it is less, then the retention of the fluid will continue, and the damaging effect of this excessive fluid in the system will cause further damage, dilatation of the heart, dilatation of the whole of the vascular system, and edema, and the further reducing the effectiveness of the heart, and the person will go into maybe death may occur. So it will go into decompensated cardiac failure. It cannot reach the normal level. So progress of decompensation in cardiac failure, CF Air stands for cardiac failure. So progress of the compensation, progressive retention of more and more fluid will continue because it has not touched the critical level of 5 liters. So more retention will continue. Kidney will be secreting less salt and water. Retention of salt and water will continue and the more fluid will be collected, and this will cause the excessive engorgement of the whole of the vascular system with extra volume of the blood. So the venous pressure will increase. Right atrial pressure is still high, so venous pressure will increase, and we again I am going to that diagram again. Right atrial pressure is increasing. Further retention is increasing the right atrial pressure, but the pumping effectiveness cannot increase. The right atrial pressure, because of the accumulation of the extra fluid, it is increasing plus 12, plus 16, but the cardiac output is not increasing. So this extra fluid, this is being added to the vascular system. Right atrial pressure, central venous pressure is increasing, and this will cause the excessive engorgement of the veins. Venous pressure, capillary pressure, all those pressure will increase, and Starling forces in the capillaries will be in the favor of that. Osmotic pressure may not be able to retain the fluid, extra fluid, excessive fluid, because of the very high capillary hydrostatic pressure will overcome this retention force of that is osmotic pressure. Then the edema will be excessive leakage of the fluid will be taking place throughout the body in the generalized edema in the right ventricular failure and left ventricular failure. This will be happening in the pulmonary side or in both sides, both left and right-sided failure may occur. So pulmonary edema as well as the generalized edema may be there. So progressive edema, it will continue, and pulmonary edema may occur, and the progressive elevation of the mean circulatory filling pressure will cause the generalized edema, elevation of the right atrial pressure, as we saw in that diagram. Right atrial pressure beyond at 6, 7, 8, there is not further increase in the cardiac output. Pumping effectiveness is not increasing, rather it will be reduced because of the excessive dilatation of the heart, because of this extra volume collected in the vascular system. So heart may go into further damaging excessive dilatation of the heart. So right atrial pressure is increasing, and overstretching of the heart is further weakening the myocardial muscles. So this will cause irreversible damage, and the person is going to die. So it will go into irreversible shock. We are going to discuss the shock in next lecture में हम बात करेंगे. So this will go to irreversible failure, which cannot be brought about to normal. So the left ventricular failure and right ventricular failure both may occur simultaneously, but the difference is between the left ventricular failure and right ventricular. Left ventricular failure, it is receiving the blood through pulmonary veins, left side of the heart, left atrium. Pulmonary veins are opening, coming from the lungs. Oxygenated blood is brought by those veins. So left ventricular failure and right ventricular failure, it is receiving the blood from all parts of the body through superior and inferior vena cava. So right atrium is receiving the blood. Right atrial failure will cause the generalized venous enlargement in the systemic vessels, and the left ventricular failure will cause the generalized engorgement of the pulmonary vessels. So this will cause the pulmonary congestion and the left ventricular failure. So pulmonary congestion will increase the pulmonary filling pressure. Pulmonary side filling pressure will increase, and that will cause the pulmonary pressure may be more than the colloid osmotic. Colloid osmotic pressure is the retention force, and this pulmonary pressure is hydrostatic pressure by this damming of the blood may be more than that, and leakage of the fluid. Osmotic pressure will be less than this leaking force, that is the pulmonary pressure, hydrostatic pressure. So excessive leakage of the fluid will occur, which is known as pulmonary edema. So edema that will cause the decreased oxygenation of the blood, because of the pulmonary membrane will be thickened. lot of fluid has been collected. So that pulmonary veins, if you pulmonary membrane consisting of those pulmonary endothelium and interstitial space and the alveolar and the surfactant, all that, if you are familiar with the pulmonary vein, so the oxygenation will occur. If edema is there, the distance between the hemoglobin and the oxygen in the alveoli is increased because of the edema. So the proper transport of oxygenation or the oxyhemoglobin formation will be reduced, and the death may occur in 20 to 30 minutes due to suffocation. Suffocation means loss of decreased oxygen supply to all the parts of the body, brain and heart and everywhere. So death will occur because of the pulmonary edema, very quick death. That is within 20 to 30 minutes of this pulmonary edema, it may cause the death. Right ventricular failure, when the right ventricle is not properly pumping, then the damming of the blood in the right atrium and in the superior inferior vena cava and tributaries of all those venous sites, so systemic congestion will occur. Systemic congestion throughout the body, generalized edema will be there, and anasarca throughout the body, there will be excessive edema throughout the body, and the mean systemic filling pressure. As we are referring to systemic side, it is the mean systemic filling pressure. Here was the pulmonary pressure, filling pressure, pulmonary filling pressure. So mean systemic filling pressure will be more because of the excessive engorgement of the veins, and the generalized edema will occur. That is, all the veins, the capillary pressure will be more, filtration force will be more, installing forces, capillary pressure is more. So excessive edema throughout the body will occur, and we can see the edema. And special feature is because the edema in the liver will cause the enlargement of the liver in edema. In right ventricular, a very common feature of this liver margin is palpable here in this subcostal spaces. So here in the hypochondrium, it is visible. So a large liver due to the edema. This is due to edema. We cannot see the edema in the large intestine. We can't palpate the small or large intestine, but we can palpate the liver. So there is enlargement of the liver in anasarca, in right ventricular failure. Enlargement of the liver is very common feature. Generalized edema and enlargement of the liver. So edema in cardiac failure, acute cardiac failure, immediate after heart attack. If it is due to the ischemic heart disease, there is no edema, but the chronic failure, because of the retention of the fluid, there will be reduction of the GFR, there will be renin-angiotensin system is also activated. You know it. If we discussed the role of kidney and renin-angiotensin system and the maintenance of the long-term blood pressure. So renin-angiotensin system is activated when the blood pressure falls or blood flow to the kidney is reduced. There is reduction in the GFR because of the reduced blood flow to the kidney. Heart failure, there is reduced blood flow, all tissues of the body, less than the required amount of the blood is supplied to all the tissues of the body. So in kidney, there will be reduced blood flow, causing reduced GFR, increasing the production of renin-angiotensin, and causing the increased production of aldosterone. We all discussed in the long-term control of blood pressure lectures. In so all this will cause the further retention of salt and water. GFR is reduced, less GFR, less urination, more retention of salt and water. Renin-angiotensin system, it will cause the conservation of salt and water. We know the angiotensin. We discussed in long-term control role of angiotensin system on the long-term control of blood pressure. And aldosterone is the hormone responsible for further retention of salt and water. So salt and water will be retained. So throughout the body, there will be generalized edema in the cardiac failure. So generalized edema will be there. So treatment of the cardiac failure, that is beyond our scope, but the basic physiology of the treatment we can talk about. That is correction of the reversible causes. Causes we discussed in the previous lecture. Those pressure overload, work overload, or the valvular disease, or the pumping effectiveness is reduced, or whatever. So correction of the reversible cause. The reversible cause, for example, ischemia. Ischemia should be treated. And the valvular heart disease, that should, if this is the cause of this cardiac failure, and this will be volume overloading. So valvular heart disease and the thyrotoxicosis and other high cardiac output, very are the thyrotoxicosis and anemia. These are the causes of the failure. So those should be treated. One is the thyrotoxicosis, anemia are very should be treated. High cardiac output should be reduced, and shunts are also responsible for the decreased resistance and high cardiac output and maybe cardiac failure. And shunts should be treated. Arrhythmia, if the heart failure is due to the loss of the rhythm, that should be treated. The drugs which are responsible for the correction of arrhythmia, that should be applied, and the medications, all the medications required for that. So the treatment will be this: treatment, diet, and activity. That is the salt restriction. If a person is suffering from heart failure, that has to be treated with the restriction of the salt. Compensated heart failure, the restriction of the salt, etc. So the salt restriction and the fluid restriction, so that edema is reduced, so that the workload on the heart is reduced. Excessive blood volume is cause of the load on the heart, and heart is failing. Uski load ko kam karein with the salt restriction and fluid restriction, and the weight reduction. So when weight is more, the heart has to supply more blood to all this heavy body. And if the person is thin and slim, if weight reduction is occur, workload on the heart or the requirement of the cardiac output is reduced. So the weight reduction is also the treatment of the cardiac failure. And gradual exertion programs, the person who suffer from the heart attacks or the myocardial infarction, they are advised gradual increase in the activity or exercise program, so that the compensation is gradually achieved in the myocardium as well. And so that will cause the that is the way of the treatment. Medical treatment, which is beyond our scope, but strengthening the heart muscle. Medical treatment should be on one hand, there should be increased strength of the myocardium, and there should be reduction in the total blood volume. Both total extracellular fluid volume, edema should be reduced, extracellular fluid volume, blood volume reduction, and the strengthening the heart. Heart is strengthened. A very commonly used drug is the digitalis, derived from the digitalis, which is cardiotonic. It causes the increased calcium in the cardiac muscle, and it causes the increased force of the contraction. So we don't have to discuss this digoxin or digitalis, but one physiological mechanism is in strengthening the myocardium by some drugs. So it will increase the force of the contraction of the heart, so cardiac failure may be reduced, and increased pumping ability may be achieved by the digoxin. Reduction in the extracellular fluid volume, that is restriction of the fluid and salt, we saw in the previous slide. That is diuretics. Diuretics have to be given to get rid of extra salt and water in the urine, which will cause the excessive increased excretion of salt and water, and that will reduce the extracellular fluid volume, reduce blood volume, and workload on the heart, that will be reduced. So that will cause the reduction in edema. So this is the line of the treatment. So then some drugs which inhibit the renin-angiotensin system, we saw in the heart failure there is excessive stimulation of the renin-angiotensin system. So we can reduce the workload on the heart by reduction in the renin-angiotensin system by some drugs. So the renin-angiotensin aldosterone system activation is the cause of this excessive retention of salt and water. If we can stop this aldosterone production and renin-angiotensin system, if we block this, so the retention of salt and water will be reduced. That is angiotensin converting enzyme inhibitors. We know the angiotensin 2 is formed by some enzyme produced in the pulmonary endothelium. So if we give angiotensin inhibiting converting enzyme inhibitors, ACE inhibitor, ACE inhibitor, commonly they are known as ACE inhibitor, but they are also called as ACE inhibitor. So they will not allow the formation of angiotensin 2, which is the culprit here in the cardiac failure, excessive stimulation, retention of salt and water, and stimulation of aldosterone as well. So the angiotensin converting enzyme inhibitors are given, angiotensin receptors are blocked, and the spironolactone is a drug which inhibits aldosterone. Aldosterone causes the conservation of salt and water, and spironolactone doesn't allow this aldosterone to perform this activity. So this will cause the use of these drugs. ACE inhibitors are the aldosterone inhibitors. So this will cause the reduced extracellular fluid volume, and edema will be reduced. Angiotensin converting enzyme inhibitors system, by inhibiting the conversion of the angiotensin 1 to angiotensin 2, I have just said. So vasodilatation will occur because angiotensin is vasoconstrictor, and the retention of salt, the sodium retention will be reduced, aldosterone mechanism will be blocked, and the ACE inhibitor, they should be capital. Angiotensin converting enzyme inhibitors were found to improve the survival of these patients, that is the cardiac heart failure, congestive cardiac failure, CCF or congestive heart failure patients go. Angiotensin inhibitors or angiotensin ACE inhibitors have been proved to be very important. This is the last a few slides about the concept of cardiac reserve. So in decompensated cardiac failure or compensated cardiac reserve has been reduced. What is that? Cardiac reserve, it is the percentage increase in the cardiac output that can be achieved during maximum exertion. It can be calculated with the following formula. So what is that? Normal cardiac output is 5 liters. By a normal person, with the sympathetic stimulation, with the exercise, etc., can increase its cardiac output up to 25 liters. In athletes, it may get to 30, 35, or even 40 liters. So this is extra pumping effectiveness which can be achieved. That is the cardiac reserve. That is calculated by this formula. Cardiac reserve is equal to maximum cardiac output in a normal person, it is 25 liters, minus normal cardiac output, it is 5 liters, and divided by the normal cardiac output and percentage calculation, this will give us the cardiac reserve. We are going to see these. So it decreases with all types of the cardiac failure. किसी किस्म का कोई कार्डियक फेलियर हो, लेफ्ट और राइट, और काज में बी डैमेज टू द मायोसाइट्स और ओवर workload on the heart or pressure load on the heart, any type of the cardiac failure will cause the reduction in the cardiac reserve. We have seen those decompensated cardiac failure and compensated cardiac failure diagrams we have seen. So cardiac reserve, that is normal cardiac reserve. Normal person, this is the, sorry, this is cardiac reserve. Normal person can achieve normal cardiac output is this, but this much is the cardiac reserve. And excessive increase may occur up to 25 liters. So cardiac reserve is tremendous in a normal person. But if it is hypoeffectiveness, cardiac reserve is reduced. Cardiac reserve is reduced in ischemic heart disease, any cause, or the cardiopulmonary myopathies, or the vitamin deficiencies, and affecting the cardiac muscles, anything which causes the damage to the myocardium, or valvular disease, any cause of the cardiac failure. Cardiac failure, cardiac reserve is reduced. So this ETT is one of the this exercise tolerance test to see the cardiac reserve. The person who have got the cardio, we saw in this ETT in the previous lecture, we were discussing, not previous lecture, the lecture on the ischemic heart disease with exercise tolerance test. Treadmill or walking up and down the stairs is the one test, and if the cardiac reserve is less, the person will go into this dyspnea, shortness of the breath. Dyspnea will occur with the exercise or uphill walking, and the extreme muscle fatigue may occur, and the excessive increase in the heart rate will occur. So the cardiac reserve, sign of the reduced cardiac reserve are this: when the person performs exercise, he becomes dyspneic, or he may feel some pain, angina may occur if there is severe coronary artery disease is there. So angina may occur, or shortness of the breath and weakness of the muscle. Cardiac reserve has been reduced, muscle is also weak. So this is the test for the cardiac reserve. Now this diagram is showing us the cardiac reserve. This is a normal cardiac. Normal cardiac output is 5 liters. It can be increased up to, that is 400% increase can occur in the normal person. 5 से 25 तक जा सकती हैं. So 400% increase in the cardiac output is possible in normal person, or in athletes it may go to up to 600%. That is cardiac reserve in athlete is 600%. And for moderate coronary disease, it has been reduced to only 200%. And severe coronary artery disease, it has less, tremendously reduced. And the diphtheria is a disease in which the cardiac reserve is also reduced. It is out of our scope, so I am not going to touch it. So diphtheria, an infective disease, diphtheria, that causes the reduction in the cardiac output. Mild valvular disease, that is the cause of the cardiac failure, and this will also reduce the normal se kam hota jayega. All these have got the. Or severe valvular disease may be decompensated cardiac failure, no cardiac reserve in those people. There is no cardiac reserve here and here. So that is the concept of cardiac reserve. That was about the cardiac failure. Next time we are going to talk about the circulatory shock. So these last two lectures, circulatory shock, I will discuss in 2 lectures as the last 2 lectures in this circulatory physiology, and inshallah ta'ala last 2 lectures are left in this system. So thank you very much. If you have got some question, you can ask in the comment section, or subscribe this to my page, and share this to most of the students so that maximum student can benefit it. Thank you very much.